Okay, with the new version 28, there have been some major changes from the version 24 model. And some of the major changes are the increase in the number of HCC categories. So that's from 86 under the version 24 to 115 HCC categories under the version 28. What this also means is that there has been a decrease in the number of the ICD-10 codes. So previously, a lot more ICD-10 codes mapped to the HCCs, but this time round there are less ICD-10 codes because they're more refined, and there's now around 7,770 ICD-10 codes mapping to HCC payment. Of this, around 268 new ICD-10 codes have been introduced this year. Also, another major change has been the renumbering and changing of HCC categories. We can also see changes to the HCC coefficient values. So under the version 28, you can see that there are significantly higher coefficients assigned to some of the HCC categories, such as under the disorders of immunity, ulcers, nephrology. So let me give you an example. So under the nephrology, for example, let's take the chronic kidney disease. Under version 24, it mapped to HCC 138 with a coefficient assigned of 0.69. But this year it has doubled. So the same category, but now under HCC 329 has a coefficient or weight of 0.127. So that's doubled. We can see another significant increase in the disorders of immunity. So under version 24, this would map to HCC 47 with a coefficient of 0.0665. And now under the version 28, it's mapping to HCC 114 with a coefficient assigned of 2.268. So that's a significantly higher weight under the version 28 model. I also want to point out that this doesn't always mean that the patient may receive a significant increase in RAF. And let me explain this to you by moving on to my next point. So another change under the version 28 is something called as the constraining HCC. And this process is basically known to reclassify HCC mappings. So where a related group, HCC group, such as the diabetes group, are given the same coefficient. So for example, let's take a E11-9, which maps to HCC 19 under the version 24 model, right? It was assigned 0.105, but now under the version 28 model, it receives a slightly higher risk score of 0.166. And that means it's all the HCC, it's all the diabetes groups that will receive the same weight. Yeah. I also wanted to point out, for example, another ICD-10 code. Let's take E1151, which is the type 2 diabetes with the diabetic peripheral angiopathy. Under the version 24, you'd get payment for 2 HCCs because this code mapped to 2 HCCs, HCC 18 and HCC 108. But under the version 28, now you're only getting one payment for this ICD-10 code because it's mapping to HCC 37 only. So it doesn't necessarily mean that the patient is getting higher RAFs under the version 28. Although we may find that some of the HCCs have greater coefficients assigned to them. The way organizations will be transitioning from the version 24 to 28 would be over a 3-year period. So we will notice that there will be a 33% blend from the version 28 model with the 67% from the version 24 model using the date of services from 2023 in the current year, calendar year 2024. But by 2026, there will be no blend and 100% of the RAFs will be calculated using the version 28 model. So for now, what organizations need to do, they need to manage both of the version models during this transition period. And managing these versions of the HCCs may create some challenges for providers, health plans, CDI members. And this brings me on to my next point about the biggest challenges of implementing the version 28 model. So some of the challenges created for the providers and health plans would be to document the conditions accurately, assign the codes correctly to the patient's true level of illness severity. Providers and CDI members and health plans will need to familiarize themselves with the new ICD-10 to HCC mapping so they can get a better understanding of which ICD-10 maps to which HCC, if it's mapping to one HCC under the version 24 model or under the version 28. So there are changes in the RAF scores, and this will impact the reimbursements. So basically, the RAF, which stands for Risk Adjustment Factor, this determines the amount of payment you are paid by CMS to the health plan for each patient. Okay. So typically, we know that Medicare Advantage organizations are paid at a higher rate for patients who have multiple conditions and who are at greater severity. And these patients are considered high risk patients. But in the calendar year 2024, the impact of the Medicare Advantage risk scores are projected to actually decrease by minus 3.12%. And what this means is that it will translate into about $11 billion in net savings to the Medicare Trust Fund. And also, CMS believes that the new version 28 model will reflect more recent utilization, costs, the way they are coding the diagnosis, and that's because they have updated the data years to 2018 diagnosis and 2019 expenditures, instead of using the 2014 diagnosis and 2015 expenditures that was used in the version 24 model. And so this means that the denominator year used to calculate the risk scores is updated in version to 2020 in the version 28 from the 2015 denominator that was used in the version 24. And basically this means that there will be improved payment to the health plans. Okay, so it's important for organizations to catch up with the version 28 because this version 28 is used in multiple other VBC programs, such as the MSSP, ACO REACH. Although it's going to be transitioned over a 3-year period, it's better for providers and health plans and organizations to really familiarize themselves with the new implementation. And it's also that so that they can understand the potential impacts of the model versions on their population. And so a good place to start would be to identify the top HCCs among the population, and then examine the impact that between the two models on the patient population. And as they say, early adopters gain a competitive edge. So having the knowledge and resources to adapt to the new models requirements will help gain a competitive advantage, but also help the organizations improve their patient outcomes. Okay. So at Persivia, we have made it easier for providers or their CDI team members to document and close HCC gaps under both HCC models. We do this by providing them with fewer clicks and a simple and easy to use interface. We have analytics that show side-by-side comparison between the version 28 and version 28 RAF HCC opportunities, and we have visualizations that will help them maximize revenue capture under the version 28 model. At Persivia, we also provide several webinars. You can follow us on our LinkedIn and Persivia blog to get the latest and up-to-date information on the version 28 model. We have educational materials such as fact sheets, infographics that explain the key concepts of the version 28 HCC model, in a clear and concise manner.